Our fourth talk today is an update on the treatment of borderline personality disorder. Very fortunate to have with us Dr. John Gunderson, probably have with us the leading national expert on the subject, and the leading national expert on the subject, professor of psychiatry and Harvard Medical School, and also professor of psychiatry. Borderline Treatment Medical School at McLean Hospital, the director of the Borderline Treatment Program at McLean Hospital.
Thank you. It's
John?
A pleasure and an honor to be here. It's a daunting task to try to give a informative talk about a subject where so much has changed, and much of what we do is task to try to give a inherently informative. This first slide is an overview of subject where so much has changed, and much of what we do is about borderline patients. The details of which first became recognized. This first slide is an overview disorder that was primarily and four major shifts in the orientation of treatment is almost borderline patients. Since the diagnosis first came, what we understood about treatment was handed down wisdom. We tried to learn from our supervisors, many of whom did not know very much, primarily and often exclusively treated with psychoanalytic psychotherapy. We tried to learn from supervisors, many of whom didn't know very much. Now our treatments are much more frequently evidence-based. That is, we tried to learn from our supervisors. At the start, treatments were generic. We adopted treatments which had been employed for other disorders. Now they are increasingly specific to borderline personality disorder alone. We tried to learn from supervisors, finally, many of whom didn't know very much. Of treatability has changed dramatically. Now our treatments are 30 years ago frequently for a group of patients who were thought to be untreatable or only treatable with at the start treatments were generic. We adopted treatments now, as it turns out, employed for other disorders. Now they are surprisingly good prognosis specific to borderline personality disorder alone. And finally, our perception slide captures treatability has changed dramatically. Improvement. 30 years ago, these were population of borderline patients followed over time. Were thought to be untreatable or only change in our perspective about the prognosis, long-term associated efforts. Now, as it turns out, this greater appreciation for the sectors of borderline psychopathology, surprisingly and their response to different forms of treatment, and the sequence by which we can expect change to occur. This slide captures dysphoric feelings are relatively easily modified. Behaviors improvement comes more slowly, but are also large quite population of borderline patients. Interpersonal styles can change, and finally, interpsychic organizations issues like self-esteem in our perspective about the prognosis can be modified, but that often takes associated with a matter of years. So I want to focus on three different aspects for the sectors of borderline psychopathology and evidence-based response to different forms of treatment, and the sequence by which we can expect borderline personality disorder is now much more widely recognized. It is part of the general consciousness of mental health. Feelings are relatively easily modified. Part of the national consciousness comes more slowly, but are also Sopranos quite modifiable. Glenn Gabbard's autobiography. Interpersonal styles can change, and finally, psychic organizations, issues like self-esteem, borderline personality disorder, even can be modified. Slides off the New York Times. A matter of years. She's a psychopathic, delusional, borderline personality, and I can say that I want to focus on three different aspects. So there is a stigma associated with psychoeducation, and that's a very important aspect of evidence-based treatment. Most clinicians say they don't like to work with borderline patients, or they're not good with borderline patients, and they try to avoid personality disorder is now much more conveyed, widely recognized. One of the ways this gets conveyed is a reluctance to give a diagnosis in the mental health field. Only 1 out of 40 increasingly patients of the met criteria for national personality disorder were actually given the diagnosis. Episodes of Law and Order, The Sopranos. This I view as a countertransference issue on the part of Gabbard's autobiography. Because of our own fears about their treatability, our own misgivings about our ability to treat them, our own sense borderline personality disorder from a previous generation that such people are not treatable, New Yorker, make us reluctant to tell them about the diagnosis. She's a psychopathic, delusional, borderline personality, and I can particularly say that because I'm a psychopathic. Notable so insofar as genetic evidence about this disorder puts borderline personality disorder side by side with other major psychiatric disorders. Most clinicians say they don't like, and it opens the door for psychoeducational approaches with borderline patients, and they try to avoid suggest that they have a special needs child. This gets conveyed rather than somebody who is simply one of the ways this gets highly burdensome and reluctance to give the diagnosis. They have somebody who has a major mental illness. 1 out of 40 disorientation patients on the part of families criteria for borderline disorientation on the part of people in the health field goes a long way towards setting the stage for an alliance. This I view as a counter-transference issue on the part of clinicians in the field. Informed presentations because of our own fears about their treatability, borderline personality misgivings about our ability have the to treat them, negative effects of our own sense clinicians still anticipate. Inherited from a previous generation that this people are overly not complicated slide make us done a sort of a very preliminary study of the diagnosis. 30 people at McLean who were given the diagnosis, 30 consecutive patients with borderline personality disorder for whom the diagnosis was disclosed for the notable first time. Insofar as a range of genetic evidence about this disorder, the most important aspect of this borderline personality disorder it was associated with much more other major attitude, not shown on the slide. It was having a major associated with compliance with treatment recommendations. And it opens the door also sets the stage psychoeducation for those patients who enter into treatment and their families to have much more realistic expectations about what can change and what are the treatments that are needed for it, rather than somebody who is a good segue into a highly burdensome, the evidence-based treatments. They have somebody who has a major mental illness. I don't know how many of you will be familiar with these 4 acronyms on the part of families, behavior treatment, like disorientation on the part of people in the mental health field. That was a long way for setting the stage for an alliance and a much more constructive home environment. It was developed by psychologist Stephen Young from New York. Informed presentation was empirically validated. I think it was 2004 borderline personality disorder. Maybe we do not have the negative effects of most mentalization-based treatment developed by Anthony Bateman, based on a theory of development overly complicated slide. Was done in a sort of a very preliminary study of treatment, which is sort of a psychoanalytic derivative. McLean, who were given a diagnosis on early development and the mother-child or caretaker disorder, child interaction diagnosis, fighting the paradigm for the first which to understand borderline psychopathology and around which the treatment is important aspect of modify is that it was associated with a much to understand their own mental states, not shown on those of other people, and the is associated with compliance with treatment recommendations. And finally, transference also sets the stage is derivative from those really one of the pioneers of this whole and their generation have much more realistic expectations about what can change and what are the treatments that are needed for it. Is based on his theory with some significant modifications. It has been shown in one trial to be very similar in its benefits to dialectical behavior therapy. I don't know how many of you will be familiar with these 4 acronyms. Pointed out in an editorial in the American Journal last year. I think his phrase is all known speak to Rome. They are all good. And they all develop more or less the same effects, although they have quite different theoretical bases. Schema-focused therapy, what do they have in common? is developed by psychologist Stephen Young from New York. They all identify goals, all identify and clarify the role of the therapist. I think it was. They're all based on a coherent theory. 2004 or 2000. Well, maybe trained practitioners. Almost all the people who are trained in this have to attend workshops initially, and then have ongoing supervision, sometimes for quite a bit of time. Theory of development of Peter Fonagy. They're all active. Therapists are very interactive and active treatment, which is sort of the psychoanalytic derivatives respond well to passive or inactive therapists. In fact, there's good reason to think that those mother-child or caretaker child interaction, providing the paradigm largely documented to understand borderline psychopathology, because they were using and around which techniques and a model for treatment which actually made patients to modify the ability of borderline patients to understand their own mental feelings, the recognition of those of other people, and their sources that they have on other people. Some variation on what cognitive behavioral therapists and finally, transference focus psychotherapy, go back to when the feeling began, what from the social context, one of the pioneers of this whole generation, encouraging people to experience their feelings and to tolerate them. And finally, all of the psychotherapy, empirically supported treatments based on his theory, with focus on the attention modification, focus attention on what the treater is experiencing. It has been shown in one trial transference very similar. It's often built into these treatments that there is something that is akin to a split treatment. And in general, the therapists are not working alone. Pointed out oftentimes editorial other therapists to talk about the case. Or they meet with another person who's treating the person, like a mentalization-based treatment. They are all therapy and individual therapy. And they all have more or less the same effects. And they meet. They have quite different. Is sometimes more theoretical, sometimes not. But I believe that there's a basic lesson there. What do they have in common? Is contrary to what we thought 30 years ago. The split treatments, they're all decrease the burden on the treaters. They all diminish the likelihood of the patient who all identify frustrated and angry at a treater will leave treatment. Rather, they'll go to the other person. They're all based on a coherent and then it becomes an opportunity for a corrective experience where trained practitioners, almost all the people who Dr. Gabbard is that trained in this, have to attend workshops. You don't agree initially, and then have ongoing supervision, and sometimes tell the patient quite a bit of time. And it's important that he knows he might get better. And they're all this is something that's very difficult for borderline patients, very basic to their psychopathology, and very constructive kind of way in which not a group of patients more than one treater respond well to passive or inactive therapists. In fact, can be there's good reason to think that those there are differences in the 60 treatments too. Psychoanalytic psychotherapy of borderline patients, the Freudian largely documented psychoanalytic problems would say what's the nature of the trouble and when did it begin, using a set of behavioral approach and a model for treatment. Let's drive around and see what happens. Patients worse on a more thoughtful way. This slide identifies focus on feelings, the recognition of feelings, for empirically based treatments. There's sources. I've put asterisks beside some variation on what cognitive behavioral treater would call the things that they emphasize in their theory. Back to when the feeling began. It's worth noting, however, that even therapies that don't particularly focus in their theory on something like encouraging people to experience may also actually focus on it in practice. And finally, all of them empirically. The exception of supported treatments, relatively small focus on interpersonal attention factors, overlap attention on what the elements is experiencing towards the patient. What's called this slide talks about. In fact, it's similarities and differences in techniques. And again, I've asked that those techniques which the developers of the treatment would like to emphasize when they say what distinguishes their treatment, that oftentimes they meet with other therapists to talk about the case. And I think, or perhaps most notable person in this is the degree to which interpretation there's a group therapy is central to the transference focus psychotherapy. So at least in theory.
They meet regularly.
In practice, I'm not so sure that it
more
is explicit and sometimes not.
I believe
that may be true for all four models.
That
what they think
again
is
contrary
in theory
to what we thought
may not
30 years ago
in
in
action,
action,
and that is a
decrease
new
the
horizon
burden on
in
the treaters,
therapy research
and diminish
to
the
identify what
likelihood
the common
of patients
processes
of
frustrated and angry at a treater
all
will
four of
leave
them.
treatment. Rather, they'll go to the
I'd
other
like to say a
person
little bit
and
about
complain.
pharmacotherapy.
And then it becomes an opportunity for a corrective
With the
experience where recognition of a significant
if you
heritable
think that
source
Dr.
for
Gabber
borderline personality
is
disorder
that bad,
and growing recognition
don't
about
agree,
the neuro
don't agree,
biological
whatever you might personally
underpinnings for the
think,
disorder with a
hyperactive
tell the amygdala
you
and
should
a
tell
failure
him.
to inhibit on the part of the frontal cortex.
Important that he knows.
He might get
It
better.
has given rise
This is something that's very difficult for borderline patients, very basic to their psychopathology and very constructive kind of way
to
in
patients.
And when the
more than
American
one treater
Psychiatric
on
Association guidelines were written in 2001, there
like,
was at that time
helpful.
an emphasis on the value of SSRIs.
There are differences in the
actual
treatments,
effect
too.
size of SSRIs and any other medications turn out to be
Freudian,
quite small.
the more
And
psychoanalytic
in practice
approach
now,
would
newer
say,
guidelines
what's the nature of the
are
trouble
being written
and when
which
did it
give,
begin? And
more
the
behavioral approach would say, let's
attribute
drive
more
around and
benefit
see what
to the
happens. Second generation antipsychotic
more
medications. Thoughtful way. This slide, one of the issues identifies
pharmacotherapy
differences
with borderline
in
patients
the
is
focus of
they
the
receive
four
more
antidepressants than people with
treatment.
major depression. I've put asterisks beside those
but
where
this very
the
complicated slide is
developers of the treater would
longitudinal,
the things
report
that they
about how
emphasize
changes in
their
depression
theory
relate to changes in borderline psychopathology.
It's worth noting, however,
And,
that even therapies which don't
basically shows that
particularly
if
focus
borderline
on their
psychopathology
theory
diminishes,
something like
it's followed
let's say,
by
cognitions.
the
May also
remissions of the
actually
depressions.
focus on it in practice.
And remissions
And certainly
of depression
all of them
are not followed by changes in borderline
the
psychopathology.
exception of DPD,
Other research
DBT
indicates
is
that
relatively
it's relatively
small focus on
unusual for
interpersonal
depressions of borderline
factors
patients to remit
overlap
before
considerably
borderline
in
psychopathology.
the elements
I think this
that
all speaks
comprise
to the
the
degree to which the depressive experiences of borderline patients, while ubiquitous
This
and very
slide talks
severe,
about,
and very subjectively disturbing,
similarities and differences in techniques
are usually
And again,
related
I've
to the fact that
asked
their life
those
sucks.
techniques which the
And
developers
treatments
of the
which are
treatment
directed
would like
more
to
at
emphasize
that
and
are more
when they say what are
going to have much more effect
these are the things
on
their
their
depressive
depressive
experience than the antidepressants themselves. Antidepressant medications,
I think
which
perhaps
the average
most
borderline patient
notable
usually has
in
3,
this,
is the degree to which
they
interpretation
like receiving medication.
is central to
They
the
oftentimes look up to
transference-focused
and
psychotherapy,
idealize the
at least in
psychopharmacologist.
theory.
They don't
In practice,
want, once they
I'm
get
not
started
so
on a
sure
medication,
that
to
it
give
is
it up.
that essential.
It usually doesn't work very well, so
But
other
that may be
medications
true for
are
all
added.
4 models, that what they think is most central in theory,
But it's very
may
unusual
not be
for
most
antidepressants
central
to have
in
much
action,
effect on
and
depression.
that
Their
is the
benefits are more apt to
new
be in the
horizon
impulse
in
sphere than they are in
therapy
the
research is to identify what the
affective
common
sphere.
processes of change.
This is a
that,
slide I hijacked
for all
from
4 of
Anthony
them.
Bateman when he gave a talk last
I'd like
week
to
at
say a
our
little
hospital.
bit about pharmacotherapy.
The importance of it is that it documents
with the
high frequency of
recognition of a
medication
significant
usage.
heritable
This is in a very
source for
broad,
borderline personality
geographically,
disorder and a growing
widespread,
recognition about
socioeconomically,
the neuro
and ethnically representative
biological
sample of borderline patients.
underpinnings for the disorder.
Medication
with
use
a
is very high. Polypharmacy is very high.
amygdala
Misuse of
and a
medication
failure
is
to
very high.
inhibit on the part of the frontal cortex.
Trials on long-term maintenance therapy.
It has given
have shown
rise
little additional benefit beyond the acute
newfound
phase.
hope to the
During the
idea that
acute
there
phase,
might be
that is when
medications
patients first
which are
appear,
profoundly
asking for help in
beneficial
highly
to
distressed states. Administration of medication
to
can be
patients.
helpful.
And when the American
Psychiatric Association guidelines are written sort of pragmatic empirical approach, which
there was at that time
it's adjunctive. It's a way of getting people involved in treatments which may affect their psychopath, their borderline
effect size
more profoundly.
SSRIs
And that
any other medications
efforts turn out to be made to taper them off medications after the
and
acute
in practice
distress
now
recedes.
newer guidelines are being written which give
How much time do I have?
more
I won't need that.
attribute more benefit to the second generation
So,
antipsychotic.
some overview comments, and then I'll end. Borderline personality disorder is a good prognosis
One of the
diagnosis.
issues in
It suffers from
pharmacotherapy
being
with
frequently
borderline patients
misunderstood
is that they receive more antidepressants
by people in our profession,
than people with major
and by
depression.
families. And psychoeducation has an important role
But
in changing
this
that.
very complicated slide is
The Congress
longitudinal
our United
report
States
about
recently
how
passed a resolution
changes
to
in
make
depression
May
relate to changes in borderline
Borderline
psychopathology.
Awareness Month.
And
It's
basically
a
shows
statement
that
about a
borderline psychopathology
newfound awareness
diminishes.
and advocacy on
It's
on
followed
behalf
by
of these largely neglected
remissions of the
patients who
depressions.
constitute perhaps as
And
many as
the
5% of the
remissions of
population, and
depression
certainly as much as 30%
are not
of
followed
psychiatric
by changes in
hospitalizations.
borderline psychopathology.
And,
Other research indicates
we need
that
to
it's relatively
get ourselves better
unusual
informed and more
for
comfortable
depression
dealing with the
borderline
diagnosis,
patients to
communicating it to patients and families.
before borderline psychopathology.
It's, I think
got a
this
significant
all
genetic
speaks to the
component
degree to which the depressive
and
experiences
this
of borderline patients, while
ubiquitous
knowledge
and
occurs
very
at the
severe,
same time that
very
we have developed
subjectively
much more
disturbing
effective
to them.
psychosocial treatments.
My hospital
are usually related to the borderline
fact that their
personality
life
disorder, and
sucks.
its treatment has become the
And
last
treatments
bastion
which are directed more at that
for
more
attention and
going to have
concentration
much
on
more
psychosocial
effect
treatments for a major
on their
psychiatric
depressive
disorder.
experience than the
My guess is that
antidepressants
that's true
themselves.
elsewhere, and that
Antidepressant
many
medications
of your
which
institutions
the-
do
I think
not
the
have
average borderline
services
patient
dedicated
uses
to borderline
3.
patients.
Not only does
I think harmful
they
for
like
borderline patients
receiving medication.
It's harmful for the training
They
of the
oftentimes
next generation of
look up to
psychiatrists.
and idealize
This disorder is
the
a reminder to
psychopharmacologist
psychiatry that
they don't
interpersonal
want, once they
context
get
is very
started
essential
on
in understanding
medication, to give
both
it
the
up.
development of psychiatric
Usually doesn't work
disorders
very well,
and
so
the
other
means for their
medications
remission
are
added. And in a larger sense, that the attention to the mind is still
but it's very unusual
an essential
for
and important part
antidepressants
of
to
understanding
have much
mental
effect
illness.
on depression. Their
Thank you very
benefits are more apt to be in the impulse sphere than they are in the
We have time for some
affective
questions. Please step up to the microphones in the aisles.
This is
John,
a
while they're
slide
doing that, I noticed you did
hijacked
not
from
include
Anthony Bateman,
supportive
when he
therapy
gave
as
a
one
talk
of
last
the
week in our
evidence-based
hospital.
therapies, even though it did about as well as
importance of it is
transference-focused
that
therapy
documents
and dialectical behavior therapy in the Cornell Westchester
high
study.
frequency of
Do you wanna
medication
say why you
usage.
excluded that?
this is in a very broad,
it was an oversight.
geographically
It was innocent. I didn't mean any
widespread, socioeconomically and
well,
ethnically representative
Glenn's
sample
drawing
of
attention
borderline
to something that
patients.
he and I
Medication
talk about
use
a lot,
is
and
very high.
that is the supportive
Polypharmacy is
aspects
very
are
high.
absolutely
Misuse of
essential for all of these
very
treatments.
high. Largely not
Trials
privileged
on
by the
long-term
developers of the
maintenance
treaters
therapy
of the treatment
have shown little additional benefit beyond the
yet
acute phase.
probably the essential
During the
cornerstone.
acute phase,
And it
that
goes
is when
beyond
patients
these
first
evidence-based
appear,
treatments. It goes
asking
towards
for
the
help
attitude
and highly
the
distressed
treaters need to have,
states
and the
that
families need to
administration of
find
medication can be
that
helpful.
these are
and it's the
disadvantaged,
important thing
highly
is to
disturbed
use it with
kids.
a sort of
They cause
pragmatic
us a lot of
empirical
grief.
approach,
It's not their
which is
fault.
that
It's adjunctive. It's a way of getting people involved in treatments which may affect their psychopath, their borderlineness. We get caught up in wanting to control or punish them, and that has just the reverse effect. Effort should be made to taper them off medications after the acute
I'm very intrigued by the differences in what the models say you should do and what in practice the therapists do. Did you speak with the model developers and what did they think about that? Is there not a connection between their theory and their practice, or
what's some overview comments? Well, and then I'll end. I think you're picking up on a specific comment I made, which is that in transference-focused psychotherapy, I think the practice of it suffers from being frequently misunderstood. The latest version of the manual for it has actually departed somewhat from the earlier model that Kernberg taught. Families. And so while there's a theoretical emphasis on transference interpretation, in actual practice, it's not Congress as prominent as one might have thought, and it's oftentimes not focused on the aggressive motives behind borderline patients, which is what in Kernberg's theory you would expect. Month. Oftentimes, in fact, the angry expressions by borderline patients, even within statement about a therapy, are now newfound awareness and advocacy on behalf of these.
From the perspective of the primary care physician, borderline patients are often seen as overutilized,
perhaps as many as 5% of the population, and certainly as much as 30%,
and often interface with the primary care doctor with comorbid substance abuse disorders when they're seeking benzos, particularly.
We need to
what recommendations do you have for primary care
get ourselves better
doctors
informed and more comfortable
interacting with borderline patients when they're not necessarily treating them for borderline disorder?
Well, there's a couple things. A very good question. A significant genetic component. You know, I'm one of the people who did this research, which showed that prognosis knowledge occurs at the same time that we had to reconcile much more effective psychosocial sort of growing up with these being the frequent flyers. In my hospital, nickname in the emergency room, borderline personality disorder, and the ones that never go away. Become the last nothing to do ever is right. I think sometimes attention, short-term interventions can have more powerful effects than we know. It's the ones that don't come back that we don't see. Disorder. When somebody does come back a lot, my guess is that and is an annoyance elsewhere, and that primary care or the institutions do not have mental health professional borderline patients. It's a signal that the treatment is not working. I think harmful for borderline patients, and the step back is harmful for the training of the next generation. Because otherwise, it gets sidetracked into somatic complaints, disorder, midnight phone calls, and all this. It's not working. That the it doesn't mean that primary care physicians and very essential non-trained professionals in the community cannot be very helpful for borderline patients. But when you have the frequent flyer and the means for their remission, probably need specialized help. And that's another in a larger sense because most borderline patients to the mind well still given treatment by somebody who understands the disorder and is trained in its treatment. Most. Thank you very much. Very better than practically any other major psychiatric disorder, you can say that. But they're often not.
We have time for some questions.
Not a whole lot of people
to the
who are trained in and identify themselves as specialists for borderline person. But that's probably what's needed for the what we used to call frequent flyers.
Therapy is one of the
are heavily burdensome and keep coming back.
Therapies. Even though it
starts out with it's not working,
well as
and you have this disorder,
therapy,
read up
and
on it, get
dialectical
them and their
behavior
parents
therapy,
to read up on it, and so that you have a
Cornell
more
Westchester study.
basic understanding of what they're confronting and what's needed.
Okay.
Dr. Gunderson, I assume as you were talking about borderline personality,
it was innocent.
Others were speaking about borderline personality as described in the DSM-4-2R. What I would ask you to do, please, is can you comment on the borderline personality organization as described by Otto Kernberg versus borderline personality disorder as defined in DSM-TR, and the prevalence, the existence of the prevalence and the treatment of the BPO.
Well, borderline personality organization, for those of you who don't know, probably the essential cornerstone. Otto Kernberg, and it goes beyond these evidence-based treatments. It goes, and the idea was that the universe was divided into people with psychotic personality organizations, and the families borderline personality organizations, and neurotic personality organizations. None of us were spared at least a neurosis. Disadvantaged, highly disturbed. The borderline personality organization absolutely included. They cause us a lot of grief. The people that are not their fault subsequently defined as borderline personality disorder and DSM-3. Viewed through that lens, actually is the bulk of the people enormously good things up here. These are the people who keep coming seeking help. Frequently, the theory of borderline personality organization included antisocial, narcissistic, histrionic, and that lots of people with severe personality disorder. It would include almost everybody with eating disorders, and it was
for your speech. I'm very
self
intrigued
disorders,
by the
body disorder. It would include a whole range of people who go beyond the borderline personality disorder.
Therapists do.
I don't know, nor will we ever know what the prevalence of that construct is in the population, since there's not a good measure for it.
Is there not a connection between their theory
in the treatment that was developed by Kernberg, it was for, and they had to limit it because, well, people with borderline personality disorder as defined in DSM, you're picking up by the people on a specific comment I made, which is those are not the same focused psychotherapy, personality, or antisocial. In fact, and you'd probably be doing a disservice to them to give them the manual for it has actually departed somewhat from the earlier model that Kernberg just a major study. I'm not sure I believe it, but so 30,000 people were theoretical emphasis on transference interpretations. In actual practice, prevalence rate for borderline personality disorder was 5.6%. As prominent, I would not have thought it was that high, and it's often not focused on the aggressive motive. Think about it, borderline patients. Half were males, which is what in Kernberg's theory you would expect. Now, I always get called to consult. Oftentimes, the substance fact, the angry expressions by borderline patients, even within the primary focus of therapy, on their substance are now. And I think that's more reactive. I think you have to focus that, but they are borderline. Okay. Anyway, that's an aside. Yes.
From the perspective of the primary care physician, borderline patients are often seen as overutilized
treatment modalities, one of which was
somaticized frequently, and often interface with the primary care doctor. With comorbid
and I just wanted to make the comment that when people have the luxury of providing DBT
what recommendations do you have for primary care
milieu programs that the focus on interpersonal can really pop up and provide a lot of the benefit that transference-focused psychotherapy can provide. And we have the luxury of offering a program like that where I work, and I just thought I'd make that comment.
You know, I appreciate the comment. People who did actually think in our own DBT prognosis is much better than we had thought. It seems to depart from the manual because the therapists get very involved in sort of growing up with these being the manual doesn't cite that as being a central thing. Nickname in the emergency room. They keep necessary in order for the treatment to work. The ones that in actual way, and I don't think you can separate it out. Nothing you do ever is right.
One more question, then we need to move on. Yes.
I think the disparity that you mentioned between
short-term interventions can have more powerful effects than we know. It's the ones that don't come back that we don't see.
I'm always
when
amazed
somebody does come back a lot,
people who are obviously borderline have their
and is an annoyance and a burden to the treater, primary care or borderline community-based
I've often thought it might be for more pragmatic reasons that the
mental health
therapists
professional
fear that they won't get paid.
It's a signal
either
the treatment is not
or unrealistically, and that's the reason the diagnosis doesn't appear. Do you have any comment? Would you repeat that figure again? What you said was the difference between those who have it and those who were told.
Because otherwise it gets sidetracked into somatic complaints, midnight phone calls, and all this. It's not working.
Those that have, I'm not sure I understood the question.
It doesn't mean that primary care physicians and non-trained professionals, those who haven't, cannot be very helpful.
Oh, I'm sorry. I thought you made a comment earlier, something like 40 to 1.
You need professionals. Yes. You need outpatient clinic in Rhode Island. That's another 40 people met the criteria doing consecutive diagnosis. Most borderline patients 40 people respond well criteria for borderline personality disorder. Somebody who understands this disorder and is trained in its is often there, and that's people even know it, but they don't want to tell patients. Better than practically any other major psychiatric disorder, you can say that. But they're often not easy to get to. I mean,
we're going to have more time for questions after our last talk.
Trained in and identify themselves as specialists.
I think all of our speakers, except Dr. Dubofsky, are going to stick around to answer questions. So you will get a chance to ask questions you haven't yet had a chance to ask.
Keep coming back.
Brian and Carol can all come up here. We'll open it up to questions for Dr. Thace as well as our other three presenters. So any of you who didn't get to speak, please step to the mic.
And so that you have
a more
basic understanding of what they're confronting and what's needed.
Yeah, hi. I have a question for Dr. Gunderson, and it's about patients with borderline personality disorder who hear voices.
As you were talking about borderline personality,
often described as being psychotic experiences, and I guess in broad terms they are. However, they are often chronic and acute.
What I would ask you
to
do, please, is
can you comment
they
don't respond to
borderline personality organization
and I wondered whether actually these are true psychotic experiences, because they're more like, to me, they're more like dissociative experiences, because the content of the voices is usually some part of the patient they don't experience, that they externalize. And I wonder what your view of it phenomenologically was.
The prevalence and the treatment of BPO.
Yeah.
It's a good question. Personality. First of all, my organization, which is extensive, those of you who don't know, was a I've seen that construct that Otto Kernberg developed in 1968. It always sort of makes dynamic sense, just as you say. It's like some part of the self was that not integrated. The universe was divided. Oftentimes not very responsive, not just not to medications, but borderline personality organizations and neurotic personality group of patients which are hard to treat with anything. At least that's been my experience. And that, in contrast to the borderline who have more less recurrent, absolutely hypnagogic experiences like hearing their mother's voice or thinking people are looking at them. That sort of thing will disappear. That goes away with time. And that actually is the bulk of the people that appear. These are the people who keep coming seeking help. But the theory of borderline personality organization included antisocial, narcissistic, histrionic, lots of people with severe personality disorder. It would include almost everybody with eating disorders and
that arrived me for treatment. And although I subscribe to
self disorders,
myself,
body dysmorphia, it would include a whole range of people who are go beyond the borderline personality disorder. Well, first of all, the distinction can be difficult to make. Nor will we ever know what the prevalence of that and without question bipolar population, since it's not a good measure for it. I don't know what the percentage is, but I would say probably 80% of the borderline patients that was developed by Kernberg was for, and they had to limit it because bipolar people with borderline personality disorder is defined in DSM. In order to get that diagnosis, you're supposed to have to have periods of elation, but it's often given without that. Those are not the same treatment. So you have a group of narcissistic personality or antisocial treated pharmacologically. And its profile of benefits from medication doing a disservice to them to give them these treatments. So that many medications work, none very dramatically and none consistently.
The incident, borderline personality
in family
disorder is
studies,
just a major study.
You don't see much of a relationship
not sure I
between
believe
borderline
it, but
personality disorder and
30,000
bipolar
people
1.
were interviewed in
You don't
this
see
country.
a real strong relationship in family studies between bipolar 2 and bipolar
And
1.
the prevalence rate for
So
borderline
there's a question in my mind.
5.6%.
I think the DSM system, I doubt that there's.
I would not have
addressed,
thought
but
it was
would
that
certainly
high.
be welcome if it could be.
It also
as to whether
documented something
a lot of people diagnosed
really
with
makes
bipolar
me
2
think
ought
about
not
it,
to
which
be
is
diagnosed as
that
borderline.
half were males.
It gives them
And
it's
that
a much better
speaks to the
diagnosis
fact
in
that
the sense that if
you
you
always
have
get
it,
called to consult.
there's a lot you can
the
do about
substance
it.
abuse.
If you've got bipolar 2, you've got a
The
disorder.
substance abuse unit
Maybe
is filled
you've got a
with people
disorder
who have
that
borderline,
there's
but
not
they're males
very
and
good
they're not-
treatments
the
for.
primary focus
And,
of treatment is on their substance.
It's very
abuse.
frustrating.
And I
for
think
people.
that's correct.
Okay.
I think you have to focus that, but they are
Dr.
borderline.
Gunderson, recently
Anyway, that's
in
an
a
aside. Yes.
psychotherapy clinic, a resident treated well a
Make
patient with
comment
depression.
on the matrix that you
And
had
when the
shown
patient moved to
regarding,
another community,
areas of focus
we
of
sought to
treatment
have
across the
continuing
four
treatment.
treatment modalities, one of which
At
was
the origin, the patient was given a
interpersonal
diagnosis of
focus.
bipolar
with
personality
the
disorder.
DBT being
And this was
on the
put
low
on the letter
end
that went to
of
a number of
focusing on
physicians.
interpersonal.
We
And
were
I just wanted
surprised
to
that
make
no
the
one
comment
would
that
accept the patient. When we
when people
inquired,
have
a
the
nurse
luxury
told
of
us,
providing
we don't
DBT
accept
treatment
patients with a
in
bipolar
a
disorder.
day
I think you mean
treatment
borderline personality.
milieu program,
I'm sorry,
Yes.
you're
that
correct.
the focus
Yeah,
on
it does get
interpersonal
confusing.
can really
Bipolar,
pop
borderline,
up
BP,
and
BPD,
provide a
you know,
lot of
it's,
the benefit that
yes.
transference focus
Well, isn't that
therapy
something?
can
I
provide.
mean, that is what I was saying
And
before. Is
we
a lot of
have the
clinicians
luxury
don't
of offering a program
think
like
they're good with
that where
borderline
I
patients,
work,
don't
and I
like
just thought
borderline patients,
I'd make
think
that
the disorder
comment.
itself
I
isn't very
appreciate
treatable.
the comment.
Or if
actually
other
think in
if
our
it can be
own
treated, it's
DBT
not by me.
program,
And there is the reimbursement issue. You know,
it seems to depart from the manual because the
clinicians who
therapists
are
get
used
very
to a
involved
psychopharmacological
interpersonally with
practice,
patients, although the manual
can
doesn't cite
anchor
that
their
as being
treatment
a
with one of these
central
other
thing. It's
diagnoses,
like it's incidental, it's
bipolar 2 or depression,
necessary in
and be
order
much
for
more
the
sure
treatment to work. But in
reimbursement
actual
than when they go to
fact,
borderline.
I don't think you can separate it out.
over there.
And yeah.
I have one question for
One
Dr.
more
Gunderman
question,
and one
and we
for
need
Dr.
to move
Days.
on.
For Dr. Gunderman.
The disparity
I
that
think
you
that
mentioned
the very
between
word personality
those who have
is
borderline
culturally and
personality
maybe
disorder
politically loaded,
and the patient being
and
told
it might
was
draw
impressive.
both the patient and the therapist
I'm always
to
amazed
conclusions, behaviors,
of
counter-transference and
people who are
transference,
obviously borderline
so on.
have
So,
their a lot of old records,
under
and there's no
the
mention
light
in the
of
chart
newer data, including
of
your own
borderline.
data,
I've
suggesting
often
that
thought it
maybe
might
half
be
of
for more
patients,
pragmatic
borderline
reasons
patients,
that
are
the therapists fear that they won't get
sub-threshold
paid
after 2 years.
either
And you have also
realistic
published that
or
there will be a
unrealistically,
late
and that's the
onset
reason the diagnosis
onset
doesn't appear. Do you
borderline
have any
personality.
comment? Would you repeat that figure again?
Is
What you
currently
said
any
was the
justification
difference between
to
those
keep
who
the
have it
word
and those who are
personality
told?
with
Thank
all
you.
its burden? And I'm not suggesting to move the
I don't
borderline
sure.
personality
Figure
into the
between
bipolar
those
spectrum
who
because this would
have
be
it and those who
political
were
or a
told.
classification decision.
Those
What I
that
mean
have,
is that the whole
I'm not sure I understood the
issue of
question.
Axis 1 versus Axis 2 in the view of latest data, I would like a comment on that.
Those who have and have not been told.
Well,
I think
I'm
that
sorry. I thought you made a comment earlier, something
borderline
like 40 to 1.
disorder.
Yes.
Psychiatric
There's
disorder, more or less
outpatient
like
clinic
the
in
other
Rhode Island.
major Axis 1
40 people
disorders.
met the criteria.
And by being on Axis
consecutive
2, it may have undermined
40 people met the
a more
criteria for
sympathetic
borderline
view towards some
personality
people
disorder,
and
only
undermined
was
proper
told about
reimbursement
it.
for its
okay.
treatment. Yeah.
Now,
It's often
the advantage
there,
of keeping
and
it. So I'm,
people even know it,
I actually
but they
think
don't
there
want to
are
tell
advantages in moving it to Axis
Thank you,
1.
John.
The issue about personality is more complicated. I think that it does create a burden on people. That's me. You're saying that it's
we're going to
me, it's
have
not an
more
illness
time
I
for
have,
questions
it's me.
after
And
our last
That's
talk.
only, it's sort of half right. And just
I
the way you
think
can say that
all
almost
of our
about
speakers,
other
except Dr.
psychiatric
Grabowski, are
disorders.
going to stick
you
around
can
to
get rid of
answer
the positive
questions, so you
symptoms,
will get a
let's say,
chance
on
to
schizophrenia, but
ask
you have
questions you
still an
haven't
ill
yet
person.
had a chance to ask.
It's not
Brian and Carol could
similar
all come up here.
model for borderline.
Open it up
If
to
a person
questions
stops
for
shouting
Dr.
and
Thace
stops
as
cutting
well
themselves
as our
or not
other
well.
three presenters.
The issue
So
of personality
any of
gets
you
into
didn't
more
get to
enduring
speak, please
qualities
step
of
to the
people that have to
mic
do with
and
the dysfunctions
we'll
which
start
are treatments, whether it's
questions
for
right away.
schizophrenia or depression or panic
go
disorder.
ahead, sir.
We get rid of
You.
those
Yeah,
symptoms,
hi.
and we don't
I've
have
got
good
a
treatments
question
for
for
the
Dr.
social
Gunderson,
disabilities.
and it's about
So
patients with borderline
that's the
personality
advantage of
disorder
keeping the personality
who
thing
hear
in there.
voices.
It's more,
because these are
it makes it harder to
often
forget that
described
these are
as being
styles of
psychotic
living that we want
experiences, and I guess
to
in
change.
broad
We're going to
terms
have
they
to
are.
stop. We're out of time. I want
However,
to thank our presenters and give them another round of applause.
Chronic, not acute. So these are people who have these experiences for years. They don't
That
respond
concludes this
to
program.
antipsychotic
This
medication.
material was recorded and
And I
produced by
wondered
Mobile
whether
Tape Company
actually
Incorporated
these
of
are
Valencia,
true psychotic
California.
experiences, because
More
they're more
information
like,
about
to me,
other
they're more
available
like
media may be
dissociative
obtained by calling
experiences, because the
1-800-369-5718
content of the voices is
or
usually
on our
something,
website,
some part of the
mobiletake.com.
patient